Hello, everyone. Thank you so much for joining us today. Chandler and Tressa here, and we are interviewing Ali Schermer. Ali Schermer is the owner of the 417 Female in Ozark, Missouri. She is a specialist in pelvic floor physical therapy and is absolutely fantastic at what she does. And Ali, I would love for you to share a little bit with us about your background and what led you into pelvic floor physical therapy, because it's such a specific niche and such a needed service that you are providing. Can you just tell us a little bit about that?
Yes, of course. And I try to get it concise down because I feel like the later I get in my career, the more long-winded I become. I teach at Missouri State and I'm like, how did I just spend 2.5 hours on this? Like normally I could have gotten through this so quick. So anyways, maybe that's why I tell little stories like that. But
I love stories.
Yes. Yes. So yes, my name is Ali Schermer. I'm from Belleville, Illinois, originally, went to Missouri State in Springfield for college. I played softball at Missouri State. And then I got to stay at Missouri State for PT school. Since as long as I can remember, I'd wanted to be a physical therapist. I really couldn't even tell you why. I had some experiences with it when I was younger, but I even put in an eighth grade notebook that I wanted to be a PT. And I was like, I don't think I knew what it was then even. So I really stuck with that. I was always very active. And so went to PT school, really not knowing what avenue in PT I wanted to take. When I started PT school, there was very limited information about pelvic health. And if you would have told me about it, I would have been like, absolutely not. I will never be doing that. I had no passion for it, nothing like that. And I thought I wanted to work with kids. And then with our class, we went to a conference called CSM. At the conference, there was a presentation that was given by one of the pelvic health providers in the US, and they did a study on women in the Air Force jumping from planes. And in this study, they found that 100% of these women, and I couldn't tell you if these women had children or not, had urinary incontinence. And that stat just absolutely blew my mind for some reason. And so that kind of stuck with me. It was in the back of my mind. I knew my mom peed her pants, and so sorry, Mom. We made fun of her for it, like a lot of kids do. We'd get her to laugh. And again, I have a lot of guilt about this. Now looking back, went on a clinical, and on that clinical, again, I just started noticing things. It was an ortho clinical, again, treated knees, shoulders, hips, all the things, not pelvic floors. And almost 100% of the women between ages 25 to 85 that we treated said that they had some degree of urinary issues, urinary incontinence. And I was just like, this is crazy. I had asked my clinical instructor, he was a male, if I could do my report on that. You had to do a report and present it to the clinic, every clinical you had. And I asked if I could do a report on that. He was like, how about you do it about the hip? I was like, okay. Right. He was actually wonderful, but yeah, we did see a lot of hip cases. Anyways, so again, just kind of sparking interest. And then later that year, I think in the fall, maybe August, a pelvic floor therapist, Crystal Warren, who's the pioneer of pelvic floor PT in Springfield, came and talked to our class, and she told us her story. And she told us about her profession. And I was just like, I need to go do this clinical. I was like, and I think I can get it. Cause in PT school, it's we're all fighting each other for where we want to go for clinicals. Right. I was like, no, none of my classmates want to do this. So I was like, easy in the bag. I got a Springfield clinical and I was interested. So I went, and I was 100% sold. So Crystal kind of became my mentor. I went to my first pelvic floor course. I had a clinical in Fayetteville that January, and then the course happened to be there. So I felt like that was divine timing. And then from there, my passion stuck. So I fell in love with this field because I felt like it was, one, obviously needed, but two, and you guys know this, you get to help people through injury, you get to help people move their body. There was just something different about helping someone through something that they didn't want to tell you about, and being that safe person that they got to talk to and tell these things, and then to know that there's an answer for that. So I really just grew in that passion for just being able to have such a big impact on someone's quality of life. And again, we know we can do that with hips, knees, shoulders, backs, and it's so rewarding to get to do. But I truly love getting to dive into those topics and just creating a safe space for someone. And just getting the word out there that these things are common, but they're not normal, and that there can be treatment for them. And looking back too, and this is something, again, that was a part of the journey, is that I had pelvic health issues, and I'd never had kids. I had chronic bowel issues. I joke with people when I teach, I'm like, you're going to hear more about my bowels than you've ever wanted to know. Just more about my body, but chronic bowel issues that I helped improve with my own pelvic floor PT, nervous system issues from being a chronic athlete and student. And then, down the road, to come to find out later, but I had known I had always had chronic pain, and recently was diagnosed with endometriosis and adenomyosis, and then myself had a hysterectomy. But that was all part of my journey and how I could relate to others too. So.
Well, I love what you just said, that these issues are common, but not normal. And that's powerful. So I just really wanted to acknowledge that you said that. And then also, just like, my whole family, like, I'll be in the kitchen and sneeze, and I'll be like, afterward. And they're just like, what happened, Mom? Did you piddle? Like, they all tease me about, it's like a known thing that Mom sneezes or coughs, and I'll like cross my legs, to like,
Chandler, my honey, I'm local. Come on.
I know. It's like practice what you preach, girl.
I know it's so hard, but it is. It's so good. It's so rewarding, and that's like a pelvic floor therapist's favorite punchline: is it's common but not normal.
Yeah. So in Tressa and I's collaboration, this interview that we're doing is going to go into our physical changes module. And the first question, just to launch into this, that we wanted to ask is, she and I talk a lot about nervous system in our work. How does the pelvic floor connect to our overall nervous system health, especially during peri and menopause?
Yes. Oh man, we could probably spend like a whole 6 hours on this. No. So very first and foremost, and again, I teach the pelvic floor class at Missouri State, which we did not have when I was in school. So love that. But I tell them too, like, we've changed over time on how we explain the pelvic floor. If you go 20 years back, all they were doing was Kegels, right? And Kegels are a voluntary movement. And what we know about the pelvic floor is our pelvic floor is mostly involuntary. It's autonomic. And so it is a driver of the autonomic nervous system. When we want to store urine and bowels, that is sympathetic nervous system, sympathetic stores. Parasympathetic is that rest and digest, and allows us to have a bowel movement, to go pee, to relax enough to do those things. And so that sympathetic and parasympathetic autonomic nervous system is what drives our system to be able to do those things automatically, to get the signal in our brain that says, hey, I've got to pee. And then our motor control is what controls that ability to say, hey, but I don't want to go yet. I don't want to pee my pants. I have the control to get there, right? We know everything in the body is so interconnected. And so, of course, hormones play a huge part in that, and talking to the nervous system and talking to that. So we know that in perimenopause and menopause, we're having this huge hormonal shift and hormonal change. And that can get a little bit confusing for those tissues, right? And so if our tissues get weaker, if we have atrophy to the muscles, now that nervous system says, well, I've known that this was the signal that I'm supposed to send, but it starts to change a little bit. And our body is adaptable, so it'll adapt for some time. And then it's kind of like the day the straw broke the camel's back, where we're like, I didn't have an injury. I didn't have this crazy change overnight, but then one day we're just peeing our pants when we sneeze. And maybe we didn't do that 10 years ago. Maybe we didn't do that 2 days ago. But when we go through menopause, that starts to happen. And so, kind of Another segment of the nervous system is that the sympathetic, parasympathetic, autonomic system are part of our stress system, right? Our stress response. And so we also know when there's hormonal change and hormonal shift, then we tend to see a change in cortisol, right? And so cortisol is the top of that hormone cascade, top of that hormone pyramid. So you've got cortisol, thyroid hormones, and then we've got our sex hormones. So if cortisol is thrown off because we're going through menopause, we're having changes, and then just we're busy, right? Like we are so used to this go, go, go mentality, especially here in the US. We don't stop to pause. And so now cortisol's thrown off, we throw off the train, our sex hormones are already starting to change, and then it affects the whole system. So I always tell everyone, my patients, my students, that the nervous system is a good thing. Pain is a good thing. Cortisol is a good thing, but too much or too little of a good thing throws the system off. So we just want balance with it.
Yes. Yes. So, oh gosh, that's deep. So what are some early signs that someone might benefit from pelvic floor therapy that we often as women will just dismiss of like, oh, that's just normal because we've been told it's normal or what have you?
Yes. So I'm going to try to ramble off my list. So basically, everybody thinks of with pelvic floor therapy, again, the reputation we get is like Kegels, and we do so much more than that, right? So you can have urinary dysfunction, whether that's urinary retention, so not being able to go to the bathroom or feeling like when you go to pee, you're pushing out. Of course, the most common is urinary incontinence. So that can be stress incontinence, like when I cough, sneeze, laugh, jump. It can be urge incontinence, like I get that urge to pee and I can't hold it. I can't make it to the bathroom. We can have bowel issues, so constipation, or on the other side, bowel leakage. So leakage can be anything between a little bit of smear in underwear that would not be normal to like obviously full loss of stool, or people will complain about. And again, I laugh, Chandler, when you're like, "Is this an appropriate way to say this?" And I'm like, "Oh, I'm gonna break those barriers really quickly." So, but there's when someone has like air release from the vaginal canal, again, no other word associated with it, but queefing.
Yep.
So we know that happens. I was going to say there's giggles are coming boy. Like, or like not being able to hold gas. And then on the other side of things, so a lot of the things I mentioned were primarily weakness issues. Constipation can be more tightness, but then we've got this whole array of pelvic floor tightness, dysfunction, pelvic pain with sex, any sort of painful insertion, inability to insert at all, which is not normal. And then again, huge array in between that. Pelvic organ prolapse. So that means that your organs start to fall down into the vaginal space. You've got diastasis. So I'm sure you guys see this in your practice, is separation of the abdomen. And again, so much nuance to all these topics now. 8 years ago, I could have these conversations and be like, nope, this is what we say about this. But in pelvic health, there's just so many opinions now. And now we're like, no, a little doming's okay because of the stress strain relationship. And so anyways, abdominal separation. And then, anything in between that, we treat scar tissue, SI joint dysfunction, pubic bone pain, tailbone pain, hip pain, low back pain, anything really connected to that. And then there's a whole, again, array of nervous system dysfunction that can happen in the pelvic floor, most commonly pudendal neuralgia, sciatica, things like that. And then again, there's a lot of hormone mediated dysfunction in between that. So
what's that big word? What's that big word you just said?
Pudendal neuralgia.
Yes. Can you expand on that a little bit?
Yes. So the pudendal nerve is, dang it, I don't have my model in here. What am I doing? So the pudendal nerve is one of the main nerves of the pelvic floor. It has both motor and sensory functions. And it basically runs between your sits bone to your vaginal opening. So there's different branches. So because of sitting, because of, tissue injury, nerve injury, surgical injury, it's one of the most common that we see in the pelvic floor, or types of injuries. So it can cause, again, pain with sitting, pain down the legs. Again, sometimes sciatica will get misdiagnosed, and it's actually coming from the pudendal nerve. And then again, just, tends to be like pain is relieved if they're sitting on the toilet because you take away that compression in that area. But, pain with sitting is the driver of that. And then, of course, you're going to see the neurological symptoms that go with it: numbness, burning, tingling, pain, discomfort, things like that.
Thank you for that. I appreciate that.
Yes.
So I think, you were quite thorough in answering the questions above, and I think that you, as Chandler said, you somewhat answered this. But if I'll go back at it, and if there's anything more specific that you can share in this regard. But for women who are going through perimenopause and menopause, what changes that are happening to the pelvic floor should they be aware of? So, like, if there's anything that you didn't touch on or that you could expound upon for that particular population, we'd appreciate it.
Yes. So specifically in perimenopause and menopause, what we're going to see is, again, that there's a potential for that vaginal atrophy. I would say that's probably the number one symptom or number one diagnosis that occurs. So the symptoms from that would be maybe having a new onset of pain with intercourse. So vaginal dryness, some thinning to that vaginal tissue. That's what that atrophy is. So atrophy means there's weakness to the muscle, and then we see that thinning in the vaginal tissue. And so they could maybe even have bleeding with intercourse, different things like that. So anytime there's a new onset of pain, we want to explore it. We don't want that to occur. You might see an increase in urination at nighttime. Because of one, just as our kidneys age, we have an increase in antidiuretic hormones. So that produces more urine at night instead of during the day. Whereas when, in our kind of adult prime from, again, I think about age 8 to about age 50, you have that normal ADH production at night. And so after age 50, that does increase. So it is normal to pee once at night after age 50. If we can get that down, we try. So we need sleep. We're going to see sleep changes, all those things. And we know, and this is one part of pelvic floor therapy that I love, and what is unique to us is that we really look at the body as a whole, right? So like we look at those stressors in your life, we look at sleep habits, we look at what's going on. And again, sorry, Tressa, I can get so far away from questions because it's also important, but I think that this time in life is hard as well because we do see a lot more life stressors. We might be taking care of our aging parents. We might be sending kids off to college. Like there's just big life changes at this point. So again, we see that change in cortisol, which then affects that hormone cascade at this point. So again, it would not be uncommon to see a change in bowel habits or a new onset of urinary incontinence because of that change to the vaginal wall.
Awesome. That was really great. I appreciate that so much. I'm learning a lot. And then obviously we know, I think it's unfortunate and it's a symptom of the fact that pelvic floor rehab is not more readily available. It isn't talked about. And I believe, and I'm sure you probably do, that it should be mandatory, it should be required. It should be, all the time as a part of women's actual health and OBGYN and gynecology, all of that. It should be much more prevalent. I added on that. But the real question is, but women are embarrassed to talk about it. And so what would you say to encourage them to seek help when they need it, or any ideas or experiences that you've had in making them feel a little bit more comfortable in seeking that help that they need?
Yes. So I think one thing I try to do personally is just talking about it, right? Just being like, there is no embarrassment to this because we all have bodies. As I joked in the period class that I did, I was like, girls, you all have vulvas. That's why you're here. So thing to change that stigma at an early age. But yes, there is absolutely modesty and embarrassment to talk about our providers with this. So I think we're in a really cool, unique time of becoming our own primary healthcare providers, right? We are our own advocates. We have to do the research and advocate for ourselves. So the first thing is finding a provider that you do feel comfortable sharing this with, right? Like if you go to the doctor and you're like, I'm too embarrassed to share this with them, do you feel a good rapport? Do you feel like you're being heard and listened to and that they're taking the time with you? So I think just starting that there of finding yourself a provider that you know that you can have that conversation with, and you know that they are going to give you options, right? Whereas again, we have a long-standing history, unfortunately, of a lot of providers just saying, well, that's normal. And, so we can't always, as much as I would like to say, I love for us to take our doctor's words for it, we can't always take their word for it. The reason for that, and again, I won't go down a huge rabbit hole here, but we're just seeing a difference in what's being paid for. So that's, just like you said, we want everybody to go to pelvic floor therapy, and insurances aren't covering it. It's one of the big reasons that I left the system, and I have a cash-based practice now, just because I couldn't do my job the way I wanted to. So, again, just making sure that if you don't know how to find a doctor that can support you in that time period, or that might do a little digging for you and find the answers. Groups are really good for that. Or again, talking to your local, message your local pelvic floor therapist. A lot of us are on Instagram now, or we're on social media, or find the pelvic floor therapist or whoever that maybe is in a different state than you, message them. And a lot of times we are so willing to help find help that we will try to help find someone locally for you. So all of that to say, that's one way to start the conversation, is just, again, feeling supported. It's hard to say too, like, talk to your friends, things like that. I think there is validation in that. But again, everybody has a different comfort level. So I think it really does start from us, the pelvic floor therapist, the providers, putting it out there and doing the education in the community to make sure that it's not stigmatized anymore.
Well, I know that Chandler and I and people in our position, we do our part, because we ask every client that walks in the door, and there really is that camaraderie. And people find out about a lot of things in the Pilates class. We're talking about those things, or we're sharing names of practitioners, and for lots of things. But certainly pelvic floor health comes up. It's one of the first things that I ask. I'm sure Chandler does as well. So yeah, that's amazing. But if somebody isn't able to have that access, or they can't get started right away, what's one simple thing that you would share that you encourage people to kind of take that pelvic health into their own hands as best they can, while they're maybe waiting to get in, or if they just don't have access to someone like yourself?
Yes. So honestly, self-assessment, like, what am I doing? Am I breathing? First of all, like, the breath is essential to life. Like, we know this in Pilates. Again, I didn't even mention that part of my journey. I am a Pilates apprentice. So yes to Pilates. And again, Pilates is just such a beautiful mesh of the pelvic floor, and putting it all together, and just awareness of the breath, awareness of the body, movement in all planes. Like, again, I don't know how I didn't fall in love with Pilates sooner, but it's okay. Everything is for a different.
It's okay.
But yeah, I'm here now. But so, okay, sorry, I got far away from the question here. This is what my brain does.
One thing that yes, no, but that was perfect. What's something they can do besides self-assessment? Go to Pilates.
Yeah.
Yes. Exactly.
No, so yeah, I mean, the breath. So really, like, focusing, like, creating body awareness, creating awareness around posture, and then again, finding an avenue of movement if they don't know how to address that. So yes, if they're going to Pilates, then they're going to get the base of the core, they're getting the breath, they're getting that movement, and they're helping with restoration of posture. And if they have that, I'm telling you, my people that come in that already do Pilates, I'm like, okay, we're going to tweak this here, we're going to tweak this there, but otherwise you're crushing it. And like, our corrections are minimal, because they already have created such a great awareness around the body, which is obviously one of the core principles of Pilates. So big advocate for just starting to move the body, become aware of what your core and pelvic floor is doing. Because if you know those things, then when you come in to see your pelvic floor therapist, if you're like, yep, when I do this, 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 and this, and then we're like, great, let's target it. Let's do it. So that can help jumpstart their journey. There's tons of online programs too. I am a big believer that in-person physical touch, physical assessment is number one gold standard way to do pelvic floor therapy. But if someone cannot do that, there are so many online programs. So I always tell people, I'm your resource. If you watch this, message me on Instagram. I'm happy. our network of PTs is, as you guys probably know with Pilates, right? Like it is like you two found each other, right? You're in Florida and Springfield, Missouri. So it's our network is so small. And so 9.99 times out of 10, I have found another pelvic floor therapist for someone in their area if they feel lost on that. So message me. I'm always a resource there. But also, like I said, move your body just any way that you can. And that can be number one way to start.
Awesome.
Thank you so much, Ali. You did I had kind of come up with another question that wasn't on our original list, but you touched on it, like, again, organically, in terms of like, if someone is, say, in a more remote area or rural area, what support can we offer them? And they can reach out to you virtually, and then you can get them some resources, and then they can always loop back around with you should they need more instruction or explanation or what have you.
Yeah, I mean, that was honestly, if there was any good that came out of 2020, right? There was so much boom of like being like, we've got to figure out how to get this information to people. So there are just, I mean, there's endless. I hear of a new program all the time. And so again, the beauty in that is that a lot of times I will have clients that are like, hey, I did this online program for a couple of years. I just want to make sure I'm doing this right. And sometimes they're not, but it's still created a beautiful foundation where they are thinking about it, and they've created motor learning and motor patterns. And so now, again, just that implementation for us is easy. It's simple that they've figured this out. And then I'm also a big advocate. There's so many people, this is again off topic a little bit, but not really. I mean, so many people that don't, or you hear this story, and I know you probably do in Pilates as well, especially, again, if we have a practice with a reformer maybe, and they don't have mirrors and they can't see, people who aren't confident in their body movement. And so sometimes it's just helping teach them, like, they are probably the person that's been told their whole life that they're not coordinated, they can't move. And so then they give up on that. And so I am a big advocate of like, actually you can, and we can teach your body anything. And I want you to stop telling your body this story of my body is uncoordinated, because we're only as uncoordinated as we believe that we are. It takes practice, right? And I know we probably all hear that all the time. So I think that things like that can be really intimidating for people to start moving their body. And then, of course, you know, the factor of leakage, incontinence, things like that. So I'm like, you know, put a pad on, do what you have to do to move your body, and then we will deal with the side effects later, because once you're moving your body, that is the key. Yeah, that's so powerful. Ali, in regard to intimacy, what changes, there's a big segue. What changes or struggles do you find that women are sharing about in the menopause process? So first of all, I love this question. I have a patient recently who came in, she was having some symptoms of urgency. So she was not coming in for pain with intercourse. She came in to pelvic floor therapy. She had a recent concussion. I think she was around the age, maybe 55 to 60, somewhere in that, been through menopause, vaginal changes, vaginal atrophy, had just started vaginal estrogen. And so again, none of that was a part of why she came in. It was not what was on her intake form. And in 3 visits, we helped not only her urgency, but she felt safe enough to share with me that she was having pain with intercourse and that it wasn't as great. And then through that, we learned that her husband was also having pelvic floor dysfunction. He was dealing with erectile dysfunction. And just through what she said about him, like, it appeared very much that it was probably musculoskeletal, not necessarily a blood flow issue, which is what we hear for men as well. So again, in just overall 4 visits, she has raved and left a review, and her quality of life. She wants to host a party, like a period party for women her age, because she is just so blown away at how much we've changed her life in those 4 visits. So to answer the question, I feel like what happens is they come in for the common concern, right? The thing that they know, okay, I go to pelvic floor therapy because I peed my pants, right? And what we get from that is that we have a super in-depth, thorough, subjective interview. And we basically give them, different opportunities to share about those things. And so I think a little bit of that comes from how we ask the questions, right? Are we approachable? Are we creating that safe environment that I keep talking about? And, this is my kind of advice for women in that is that, unfortunately, there's good PTs, there's bad PTs, there's good doctors, there's bad doctors, there's good Pilates instructors, there's bad Pilates instructors, right? There's a mixture of all of us. So similarly to what I spoke about with the doctor earlier, if you have an experience with a pelvic floor therapist and you're like, ooh, I just didn't get a feeling that was it, then we try to find maybe a better fit, because you should feel safe to talk about these things. Now, I will say, I think our profession's really cool. And I think that it's created a lot of people. Again, if we're talking about these things, usually we try to be approachable with it. So I think that most pelvic floor therapists do a really good job of helping with that environment. So all that to say, we really invite that in that conversation. And I would say 9.9 times out of 10, they will share that with me on the first visit.
What's interesting is that as taboo as the subject of incontinence is, it's still way more acceptable than the pain with intercourse conversation.
Mm-hmm.
Yes.
Would you agree?
100%. And I think there's a lot of stigma around the pain with intercourse conversation, right? There's stigma that I'm doing something wrong, or I'm not enough, or it has so many layers. One of my favorite books is Better Sex Through Mindfulness. Because again, we know as women, like we tend to, and I say we, not just generalize, but most women have a constant to-do list, right? So for women, it takes about 20 to 30 minutes to become aroused, right? And we typically, again, I say typically because it's not always the case, but typically for our male counterparts, it is not that way. It's a lot quicker, typically. So I think a lot of women, rush into intercourse because, again, we're trying to please our partner, just get it over with. But what we don't do is take the time to be like, I deserve to enjoy this. I deserve to feel good in this. And then add all that to the equation. And then we have these hormone changes and it becomes this like overwhelming, daunting thing as we age. But we should be having intercourse till we're 90.
Yes.
And we should enjoy it also.
We should enjoy it. We should enjoy it. Women should be having orgasms. Women should be enjoying intercourse. And I think there's just, again, so much that we don't talk about in between. And it's a social stigma. And just a lot of things, like back to the conversation of not wanting to talk to our doctors about it. So I think the other cool thing is that, I can't prescribe medication, but I can make a very simple suggestion of, hey, have you thought about vaginal estrogen? And, it's just a teeny little dose. We know that it does not go into the bloodstream. It doesn't tend to have the systemic effects that oral does. And it can be a really, really quick solution to that discomfort and pain, and really help with rejuvenating those tissues.
Ali, thank you. This is great. I wanted to kind of get a little deeper with when it comes to pain with intercourse, and you have the vaginal dryness and you have the vaginal atrophy. What is it about? Why is like just not using a good lubrication not enough? Or is it enough?
It depends. It depends on the person. And it depends on the state of their hormones, right? Because we know that there is an absolutely normal drop of estrogen that occurs in peri and postmenopausal, and that's physiologically just a part of our design. But what we do know is that we've been surrounded by xenoestrogens for the majority of our life in, what we're using to clean, what's around our bodies, chemicals, what we don't have control over in the environment. So there's a huge factor there. There's a very large percentage of women who have been on hormonal birth control or some sort of hormonal intervention prior to menopause. So if you have been, then when you go through menopause, it can also affect that transition. So we'll see just bigger dips in that change in how our body knows how to regulate that, because for years our body didn't regulate it. So if we are on birth control for 20 years and then we suddenly get off, we can't expect our body to just suddenly know how to process those hormones again. So that's a challenge there. And then, like I said, genetics play a large factor into that. So, if your mom went through menopause gracefully, you are more likely to have that experience. And so talking to our moms about that experience, if we have that ability to. So yeah, did I answer the question fully?
I think so. I think, yes, thank you. And then to kind of wrap it up, Ali, and your message, like your big, like if you could like zoom out to what we sometimes call the 10,000 foot view, what you could shout from the rooftops, what do you want? What's your message? What do you want people to know?
I just want people to know, yes, I want people to know we're here and that there is help and that they don't have to struggle. And I just like to encourage people, like, big messages, being that primary care provider for yourself, being that advocate for yourself, and knowing we deserve more as women. We deserve to feel good. We deserve to have good sex. We deserve to have strong pelvic floors. We deserve to not be in pain, and to be taken seriously. And again, I think for women in that peri and post-menopausal time, it can be a time where we don't feel like our concerns are taken very seriously because they say, well, you're just going through menopause, you just got to deal with it, right? Which is common to a lot of times in our lives. You just have to deal with painful periods. You just have to deal with this. And we know that there are answers and there's people to support. So yeah, that would be my biggest advice, is keep fighting for yourself. If you're here listening to this, you are seeking out resources to help your body. And, if I were to put it into terms simply, is love your nervous system. And I know, again, that could sound like I'm putting a plug into this course, but I'm not. You could eat the diet, you can do the hormone changes, you can do all the things. But if you don't start with your nervous system and start with, how can I, again, I always say, like, I heard this and I was like, this is so good. We always think we could just go on a retreat and like calm our nervous system and then come back and like we're suddenly fine. But the best advice I ever heard is that like you still have to come back to that environment that caused the stress. So you have to learn how to mediate your nervous system and control that when you're in a chaotic environment. And so learning to manage that, having tools for your nervous system, the nervous system, again, goes back to cortisol, which is the root of the trickle of the cascade. So we can age gracefully, go through menopause gracefully, and do all those things if we do that. And Chandler, I want to say too, one of my favorite quotes was a Native American saying that was in a book called Balance Your Hormones, Balance Your Life. And they say, when you first get your period, I'm going to butcher this, I think I got it. When you first get your period, you meet your wisdom. When you are in those middle years, you're becoming your wisdom. And then when you go through menopause, you are your wisdom. And so I think that there is so much wisdom in that, of like trusting that there's a reason why our bodies are the way they are and that we need to lean into that.
I love that quote so much. That's beautiful.
You guys will have to look at it and put it in the notes if I butchered it at all.
Yeah.
You get the gist. So it's so good.
Well, Ali, again, thank you so much for making time for us today. I know you are time poor like the rest of us and have a very busy schedule, and we just appreciate you so much. Again, this is Ali Schermer. She is the owner-operator of the 417 Female in Ozark, Missouri, and we would be happy to put you in touch with her if you have further questions or need support. And you'll be seeing her alive and well on our social media and such too. So again, thank you so much, Ali.
Yes, thank you guys for having me. What you all are doing is amazing. Again, I know if they're here, then they believe in that as well. But women need this. So I'm excited to see the product at the end.
Awesome. Thank you so much. We appreciate you. It was great meeting you.
Nice to meet you too, Tessa. Bye.
Take care.
Bye.